The United States Preventative Task Force Service is a group of experts that dictates the recommendations for screenings, especially in a primary care setting where you have patients who may be at risk of developing cancer or disease. This is so important. And I kid you not, you will get this on every single exam you take in medicine. So, as a pathologist, I don't deal with USPTF recommendations all that often, but these are my quick tips to succeed on your exam because this is how I remembered everything, and I hope this helps you get every single question right. You'll be asked, what is primary prevention? This is obviously preventing the disease before it even happens. What is the best example of this? Vaccines, right? We want to prevent an illness, and vaccines have been proven to prevent an illness. What about secondary prevention? Well, this is early detection of disease, so prompt treatment can get started. And this is exactly where this lecture comes into place. USPTF, they screen. They want to detect something as early as possible before it develops further. Tertiary prevention, this is a little bit different, and you will encounter this also in patients who already have a disease, but they need further workup and treatment to prevent any further disease development. This best fits into an example of a diabetic who obviously has diabetes, they've been diagnosed with it, but they need further measures taken to prevent further development of diabetic retinopathy and ulcers and other illnesses and organ systems that might be affected by their diabetes. One of the most commonly tested is mammograms. What does the USPTF recommend? Well, the starting age is 50, especially in women who may not even have a history of breast cancer. This is for an average risk person on the street. 50 is the starting age up to 74. After then, the risk of cancer isn't really factored in at all. But the recommendation is to do it every 2 years. So, pretty easy, right? Well, let's take it a step further. What if they have a family history of breast cancer? For example, first degree relatives. Your patient comes in and says, hey, my friend, my neighbor, my aunt, my cousin has breast cancer, and I want to make sure I don't have it. Well, sorry, it doesn't really matter unless they're a first degree relative. So if they are a grandmother, sister, mother, that is when you're more worried about breast cancer risk, and that's when further testing is needed. So most likely you'll do a BRCA test. Otherwise, they'll be doing a mammogram, and there's further workup indicating what, depending on the biopsy and ultrasound, that's a whole different lecture. But for now, just remember first degree relatives is all that matters when you factor into the history of breast cancer. Colonoscopies is a huge point of testing. It recommends to start at 45 years. How often? Every 10 years. So a normal person who has no risk factors, every 10 years is sufficient. However, they might find polyps, and that is a whole can of worms, which probably won't be tested on your exam, so don't worry about it. But if they find something that's cancerous, precancerous, the screening interval may be every 3 years, every 5 years, but don't worry about that. Just focus on starting at age 45. And now the development of fecal DNA test is coming more into play and is easier for patients. That might replace colonoscopies, at least for screening. But don't worry about that for your exam. That is just something to keep your eyes out for. So you have a 20-year-old patient whose father got diagnosed with colon cancer at age 40. He wants to know when he should be screened. Well, there is an equation to remember for this, super easy. All you got to do is remember the age of the first degree relative that has cancer minus 10 years. So in this case, the father was 40 when he had cancer, minus 10 is 30. So this patient should start screening at age 30, which is a lot younger than age 45 recommended. So that's because they have a history, they have a risk. You want to pick it up earlier. Lung cancer is so common, you will encounter it very often in your clinical practice. They recommend that you start screening at age 55, and only if the person has a pack year history of 30 years, or if they are a current smoker. They are screened annually by a low-dose CT scan, and they will give you all these other options: chest x-ray, PET scan, MRI. Don't even answer it. Don't even think about answering those. Just go straight to the low-dose CT. All those other exams aren't going to give you any information, or they're too expensive. So a chest x-ray is not going to be able to assess any soft tissue cancers. The PET scan is way too expensive, way too much information than we need. That's more for metastatic disease. An MRI is obviously way too expensive. It's just not necessary. So remember, low dose CT scan. You have a 60-year-old patient who is in a normal state of health. He was a former smoker from age 18 to 38, and he smoked 2 packs a day. Is lung cancer screening recommended? Well, let's think about how many pack years he had. Well, he smoked for about 20 years, and he did 2 packs a day, so that's about 40 pack years. So yes, screening is recommended because it is greater than 30 pack years, and you'll do a low-dose chest CT scan. This is like one of the most important slides you should remember for your OBGYN shelf exam, and even just in general for the boards. Depending on what the pap smear comes back with, that will determine the screening interval and next steps. So we love next best steps questions on the level and shelf exams. So here we go. Normal screen, every 3 years. Nothing to it, right? Super easy. But ascus, what is ascus? It's like atypical squamous cells of undetermined significance. It's borderline. We don't really know what it is, but it's not like normal. It's not really low grade. So that is a very confusing area for people. But what do we do to circumvent this question? We recommend pap smear or repeat the pap smear in 1 year. From there, you can proceed to the next best step. It might come back normal. It might come back low grade. If it comes back low grade, what do? Colposcopy, and then repeat the PAP in 1 year. So it comes back low grade, you have the patient come back in, you do a colposcopy, you take a punch biopsy of their cervix where it looks abnormal, and send it to pathology for further workup. And it might come back low grade. And so in that case, repeat the pap smear in 1 year. What if it comes back high grade? Or what if a pap smear reveals high grade? The next step would be a loop electrosurgical excision procedure, the LEAP. What is a LEAP? It's basically this knife that cuts out the ectocervical canal or endocervical canal and takes out all those cells that are where the cancer is arising, and that is sent to pathology for further assessment to see if it's high grade or what else is going on. And then from there, I'm sure the patient would need another pap smear, but don't even worry about that. LEAP is going to be your answer for high grade. So remember, LEAP high grade, jump high, get it? For atypical glandular cells, you will probably only encounter this in clinical practice, but if you come across it on your exam, do not fret. Glandular cells arise from the endometrium. We don't get glandular cells in the endocervical canal or the cervix, right? So usually you will see glandular cells normally from menses, right? But when they're atypical, we're worried about premalignancy or malignancy. So what do we do next? If we have a report that comes back with atypical glandular cells, we would do an endometrial biopsy. And that's that. So hopefully this simplifies everything. But if you have questions, feel free to drop it in the comments and we'll figure this out further. What about prostate cancer? Sorry guys, there really is not any verified evidence-based screening for prostate cancer. So if they ask, should they do a PSA? Should they do an MRI guided biopsy, prostate biopsy? No, that's not like a routine recommendation. Now, if they have a history of it and they have enlarged prostate nodules on a rectal exam, then that's when you would do further workup. But for as far as screening, there's no screening recommended. What about osteoporosis? You have a 65-year-old female that comes in for her annual Medicare exam. What do? There's going to be a lot of questions like that. They're 65 or older. There's going to be quite a few recommendations. But remember, for women, especially when they're over 65, they're going to need at least one DEXA scan. And that is like a full body scan looking for osteoporosis. And there's a whole equation that we will address later, depending on the value of the T value from the DEXA scan. Don't worry about it, but as far as right now, DEXA would be your answer for 65 or older. What about an abdominal aortic aneurysm? They recommend over the age of 65, mainly for men who have ever smoked, ever. And the modality is going to be an abdominal ultrasound. This is when you are going to screen the abdomen for an aneurysm in the abdomen, because smoking can cause vascular changes, especially in the aorta. So any man who has ever smoked over the age of 65, do this screen ultrasound. And what about depression? Well, starting at the age of 12, the PHQ-9 comes into play, and this is a regular routine screen for depression in basically 12-year-olds going up. So from there,